Always the attention getter.
Right.
Okay, the person who is having an issue got it. So I
Awesome.
think
We're good.
everyone I've checked in with seems to be able to see us.
Great. Thank you. Okay. Good evening, family, friends, community members, allies, and all of those who have joined Philadelphia Fight's community conversation on monkeypox. Thank you for taking the time to learn not just about the monkeypox virus, but also how we can protect ourselves and what to do if exposed, and so much more. Before we begin, we have a little bit of housekeeping to take care of. First, we'd like to thank you, the community, for sharing this event, sharing information, reaching out to ask questions, and just getting involved. Next, thank you to the entire staff at Philadelphia Fight. Please know your collaboration, support, and partnership has been invaluable. Also, a quick shout out to the Mazzoni Center for an informative town hall last night. Thank you for your hard work and also educating the community. Now, a brief note. Portions of this event contain graphics of sensitive nature. We will warn you before those images appear to give you the opportunity to minimize your screen if you do not wish to view these images. We will also make an announcement once those images are off the screen so you can rejoin. This recording in its entirety will be available after the event on Philadelphia Fight's Monkeypox information page, as well as on Facebook at JD Evans Solutions. Many of our partner organizations will share the recording as well, and a link will be sent out to everyone who has RSVP'd for the event. And with that, let's get to it. Allow me to introduce someone who, up until a month ago, when we first started planning this community conversation, but has quickly become a trusted colleague as well as a friend, Cameron McConkey of Philadelphia Fight. Cameron, please take it away.
Oh, thank you so much, Jason. That means a lot. So hi, everyone who's listening in the virtual world. My name is Cameron McConkey. My pronouns are he, him, his, and I'm the Director of LGBTQ Health Initiatives at Philadelphia Fight Community Health Centers. I want to save as much time in this conversation for the questions and content that you are all looking for, so I'll keep this very brief. But Jason, thank you so much for helping to organize and coordinate this. I really, really appreciate it. And I am at that point going to pass the baton and introduce you all to one of my colleagues at Philadelphia Fight, Dr. Janet Hines. She's a physician and an infectious disease specialist, and she cares primarily for patients through our Jonathan Lax Treatment Center for folks living with HIV. She's going to really be kind of taking the lead on this conversation tonight and answering hopefully as many of your questions as we can get to that you all have submitted through your registrations and that we've heard from community members over the last couple of weeks. We're going to get started with a little bit of foundational information from Janet, from Dr. Hines, and then we'll jump right into a conversation that's facilitated by Jason and really fueled by the questions that you all have sent us. So Janet, I'll kick it to you.
Thank you so much, Cameron. And Jason, thanks to both of you. It's a real honor to be here tonight and to be asked to do this. It's a real honor also to just be part of Philadelphia Fight. So I'm just grateful for all the presence of everyone here. And grateful to the community for learning from them, and hope to do my best here. So. What I'd like to do is start off with the background about, how did we get here? I feel like the story of, what we're going through really needs to be a narrative. It needs to start at a certain point, and it helps us make sense of what we're seeing in front of us because it's all happened so very suddenly. So, and with that, Cameron, would you be able to pull up my slides?
Yeah.
You okay? Thank you so much.
See here.
And we'll go on to the first slide. So, so this, and this actually maybe, is it possible you have the wrong presentation up? Let me just see here. I apologize.
That's okay. My apologies too. Let me check. I thought I made sure that I had the newest one.
It must be the other one. So as Cameron's doing that, I actually can start to talk. And monkeypox is the name of this condition, and it's actually a virus that is, what you look for, there's a picture on slide 2. So that's the difference. So this virus was actually first identified in some monkeys that were being used for research in the 1950s. And, it was only relevant to the veterinary population or the veterinary world at that time. Although they subsequently identified that they could find the virus in certain mammals in Central and Western Africa. And these were, and if you can't find it, I think I can go with whatever you have.
I think the recent file you sent me looks like it was the same as the old one.
Oh, it's my fault then. Okay, let's see if I can do one more thing here.
Janet, while you're finding the correct file to send to Cameron, we could just take a minute to again thank the community for being so involved and engaged, from the text messages, the calls, the DMs, the emails, the heavy response rate we had to people just signing up for this event to get educated, to learn about what we're, as this is a constantly evolving virus, we're learning a lot of information every day, and even like multiple times throughout the day, we're receiving updates. And it has been quite busy for all of us, in several meetings, learning as much as we possibly can and working to get this information out to the community as often as possible. I'm going to drop in the chat here. Philadelphia Fight has done an excellent job as far as updating their website. They have a dedicated monkeypox information page, and it has just tons and tons of information and links of where you can find more information to educate yourself, learn about what you can do to protect yourself and others. And it's just been a great resource that I encourage you all to check out, of course, after this live event. I will drop that in the chat right now. And how are you guys doing over there?
Oh, it's loading. So let's go with what we have. And Cameron, if you see it come in, it's
Make the switch.
Make the switch. Actually, it might come in a second. So this is what you always wanted to have happen when you're on a live stream and Zooming and all that kind of stuff. That's my favorite kind of technical problem here. So my apologies.
No worries. We've been at this for 2 or 3 years. It's going to happen. Technology is going to, it's always an unknown variable, and we've learned to roll with it. So
yeah,
the fact that we have the information, we can keep rolling with it.
All right, let's see.
It should say Zoom 2.
Yeah,
but if
there we go.
I'll go with whatever you have, we can roll with it.
All right, we'll get this started. Just okay. I've got something with pictures. There we go.
There we go. Oh boy, we're not going to try to do fancy next time.
No worries. No worries.
Okay.
Okay, there we go. Thank you so much, and I appreciate everyone's patience. As I mentioned, it was first identified in 1958 in monkeys that were being used for research, and they learned that this virus would also just live inside of certain kinds of mammals in Central and Western Africa, and mostly the animals didn't have any symptoms, so there wasn't really any effect on the population there. We can go to the next slide. Now, starting in 1970, there started to be outbreaks in humans in Central and Western Africa, and mostly these would happen in children. These were primarily in the rainforests of these areas, and it's thought that the children acquired the virus by, contacting and, playing with the infected animals. So when the children contacted, if the animals did have any lesions, they would actually acquire the virus from those lesions. And the next slide here. In 1977, a different virus, smallpox virus, was eradicated. And this was a really horrendous virus that the mortality rate of smallpox is 30%. So it was really tremendous that smallpox was eliminated from the surface of the earth. And in 1980, well, that's another story, but in 1980, they stopped vaccinating people because there was no need anymore. And so now what this sets the stage for is that people who grew up after that time, people who were born in, the very late 70s and early 80s, really grew up without any immunity to smallpox. And so they also had no monkeypox immunity. Those viruses were closely related enough that they would cross-react and protect each other. And so this sort of led to the number of cases of monkeypox increasing in these areas of Central and Western Africa. Next slide. So bringing us up to 2003, and there was an outbreak of monkeypox in the United States. And what was going on there is that Gambian rats were sort of trafficked into the United States for the domestic pet trade. And they were sort of housed with, I'm trying to remember what the other animal was, but kids were adopting these animals that had been exposed to monkeypox and infected with it. And there were outbreaks in different parts of the United States, I think maybe 20 cases, something like that. But in each of these cases, you could transmit from human to human, but it didn't go very far. Like there might be another person in the same household who got it, but nobody else got it outside of the household. So it was nothing like what we're seeing today. Next slide. So then bringing it forward to 2017 in Nigeria, and I like to give credit, this story was written up nicely and actually was reported on NPR. So there was a very large outbreak of about 200 cases, of which 60 were confirmed. And Dr. Dimi Ogwina, who's pictured here, he wrote this up and published it in PLOS One, which is an online open access journal. So he published their experience in his hospital, and he first identified a case in an 11-year-old child. So what happened is the child looked like he had chickenpox, but he knew based on the kid's records that he'd already had chickenpox and you shouldn't get it twice. He also had lesions in his mouth, which weren't typical of chickenpox. So he knew that there were cases of monkeypox in, actually distant from Nigeria, not actually in Nigeria recently, but in other parts of Western Africa. So he actually sent testing out for it and it returned positive. And you can see the lesions on the feet of this child, which is reported in this journal presentation. Next slide, please. So in Nigeria in 2017, more and more cases were identified, but unlike the other outbreaks that I mentioned, in this one, they weren't in the rainforests and they were instead in towns and cities. And instead of being with the kids who are playing with the animals, that had it, the monkeys and the other small animals, this was happening in adults. 80% of cases were in adults, and it was predominantly in males, 80%, more than you would predict by chance. And a large proportion of them had genital lesions. So what we know is, we know now, and I think they suspected then, is that when you, the very first exposure that you have, like the inoculation site of the virus is where you have the first lesions present, and that's where you have the most lesions. And so he and his team went back and did detailed sexual histories of many of these patients and found that they had reported multiple partners or had been engaged in commercial sex work. So it was limited what he could do because this is a very, having, certainly having sex with male partners was very stigmatized, if not illegal, or illegalized. I'm not sure the right word there, but it was a very difficult environment in which to advocate for his patients. He really wanted to get vaccine for them, but he couldn't. Now in 2018, however, the number of cases fell. So you would think that that's because they, stopped transmitting person to person. But he himself stated that he continued to see many, many cases, and he felt like the actual reported cases through their public health system were not accurate. And NPR actually tried to reach out to the public health authorities, who didn't comment. So as I mentioned, he tried to advocate for vaccination, which, as you probably know now, there is vaccination available. And smallpox vaccine has been effective against monkeypox, but to date, no doses of monkeypox vaccine have been given in Nigeria, despite the fact that there are so many cases. Next slide. So that brings us to now, or actually May of this year, just 2.5 short months ago, where multiple clusters of monkeypox were being reported in countries outside of the endemic area. And by endemic, I mean this is where these cases had been existing for 20, 30, 40 years. So now, as of August 2nd, yesterday, there have been 25,391 cases reported globally. And in the US, there have been 6,326 cases. And you can see by the size of the circle in each of these countries, the countries that represent the highest numbers of cases. And the blue dots are where the endemic disease exists. Let's go to the next slide. So again, in the US, as of this is July 26, when you look at, these are basically our public health authorities collect information when cases are reported. And I'll highlight over here on the right, it says data are missing for a large number of cases. So they can easily get ages and, the sex assigned at birth. And the most dramatic thing about just that information, which is probably quite accurate because it's simple information to collect, is the vast majority, I mean, almost exclusively males, 99.1% were assigned male sex at birth. And then 99% of these males who gave a sexual history, and this is not the part that you have the most information about, but where they were getting sexual histories, 99% of males were reporting male sex partners. They give a race distribution, which I'm not sure if it's accurate because it also may be information that they didn't completely ascertain. I should mention that because this condition has been presenting in people who are sexually active, they're often in people who are looking after their health. They're accessing healthcare in sexual health clinics, some of them in HIV clinics. And so that may be part of the reason why there are a lot of people reporting sex, but it's probably not all of the, it probably doesn't account for all of the reason. So just to recap, we know that humans can acquire monkeypox from animals by contact with the skin lesions or secretions. And we know that humans develop the very first lesions at the site of inoculation. Back in the 70s, when children were playing with animals, they would develop lesions on the hands and face. But in this global outbreak of 2022, as well as the Nigerian outbreak since 2017, lesions were often seen in anogenital areas, as well as the rest of the body, including the face, trunk, palms, and soles. Next slide. So this kind of leads to this hypothesis that close contact during sexual activity is a very efficient mode of transmission. So meaning that the explanation for the reason that this is so overrepresented in cisgender men and transgender men and non-binary men having sex with other men is that the degree of close contact during sexual transmission is just very efficient. It's the most likely way for somebody to get transmission, to get infected. So the people at highest risk, therefore, are a gay or a bisexual man, or a transgender non-binary person who has sex with a cisgender or transgender or non-binary persons. And so that's why we are here. The important thing to emphasize about that is that you notice I didn't say anything about the virus being present in the sexual fluids. It isn't required to exchange sexual fluids in order to get monkeypox. So this is why there's dual messaging out there that, you know, this is predominantly affecting men who have sex with men, and anyone can get it. So no one is, excluded from being vulnerable to getting infected with this virus if they have close contact. It does not have to be sexual activity. But because of the way that this transmission is occurring so quickly, again, the people at highest risk, in addition to being what I mentioned, but are also those who've had multiple known partners or any anonymous sex partners in the last 14 days. Also, anyone who's been exposed to an STI or sexually transmitted infection or monkeypox in the last 14 days. And we'll talk a little bit about what an exposure is. And those who've been newly diagnosed with a sexually transmitted infection in the past 3 months. In other words, gonorrhea, chlamydia, and syphilis. Next slide, please.
And I just, if I could sort of jump in for a second, Janet, because I think this is really important, and you mentioned it, and I want to just sort of reiterate it and kind of hold it as a mantra for us throughout this conversation. One, and I know that you also have had your ear to the ground listening to the community and what's been shared online about this. Can we definitively say right now that this is not a sexually transmitted infection, and that it's very different than sexually transmitted infections like gonorrhea, chlamydia, and early syphilis, like you have mentioned there?
Yeah, thank you for that question. And I'm gonna give a little bit of a nuanced answer to that. So the first way to think about that is the virus present in semen or vaginal secretions? It is found in those fluids. It is not yet clear if it could be transmitted that way. And so in some ways, I don't want to say that it is not a sexually transmitted infection. I think it's hard to have exchange of bodily fluids, of semen, without close contact. I mean, it's certainly possible, but it's not the common way of people interacting. And so the way that I like to think of this is, here's an example in the pediatric world. If a child is, gets tested positive for gonorrhea, this is an automatic case of, something, someone has been violated. This is a case of sexual abuse if a child is diagnosed with gonorrhea. So from a laboratory standpoint, it's a very important point. If the same child, or obviously a different child, were diagnosed with monkeypox, it does not imply that sexual activity has happened. And that is like a really important point that could be misunderstood if we call it a sexually transmitted infection. And it's part of the reason why, this idea of stigma is so complicated and complex. And there's so many facets to it. But one of the facets is that if I come down with monkeypox, people who know me are going to wonder, what did you do to get that? And first of all, it's none of their business. Second of all, it could mean a lot of things. And it could mean that I hugged somebody that I loved. And it could mean that I had sex. Could mean that I had sex with multiple partners. There aren't conclusions that should be made about my diagnosis of monkeypox. It's mine and my life is private. when, if I show up with lesions of monkeypox, I'm going to be judged. And that's more difficulty than I should have to go through when I'm the one with the disease. So I don't know, did sorry if I went on too long for that, but did I answer your question?
Absolutely. No, thank you so much. And I think how you sort of contextualized all of that was really, really important. And if it was appropriate to snap on a call, I was definitely giving you some snaps there at the end, because I think this conversation around stigma is a big part of what we're hoping to educate the community about. So thank you.
Okay, thank you. Okay, so in terms of understanding what's going to happen to me if I get monkeypox. Let's say I have been with someone that they didn't know they had monkeypox, and you know, we misinterpreted what something on the skin was, and then they find out they have monkeypox. Well, that was 3 days ago, and I have to wonder, am I going to get this? I have to go through this period called the incubation period. And that's a period after I've actually been exposed and may or may not have been infected, but there are no symptoms. So if there's virus in my body, it's just doing what it's doing. It's not going to do, it's not going to give me any signs for some period of time. And the average incubation period is about 5 to 13 days. And if you had to guess, it would probably be an average of like day 9. Day 9 is sort of like the most common incubation period. No, that's not based on this current epidemic. It's based on when kids were exposed to animals, because it's a little easier to say when the exposure happened. So again, during this period, no symptoms, but then there's a point where I may develop a fever and I may get swollen lymph nodes. Those lymph nodes may be in my neck if I was, you know, if I was exposed in the face. It may be in my abdomen or in my in the groin area if I was having sex with someone. But in addition to those symptoms, I would also probably have a headache and chills and sore throat and just feel gross and fatigued. And that's the same symptoms that can happen with the flu and with COVID and so many other things. So it doesn't really tell us for sure that it's monkeypox. And we call that a prodrome, but that prodrome may also be absent. So there's some people who never get that sick with it. So that period of time with no skin lesions is about 1 to 4 days. And then a rash starts to develop. And I'll talk a little bit more about the rash. That rash period lasts about 2 to 4 weeks. So this is a pretty long condition. And during that period when there is a rash and during the period when I have fever, I can be infectious to somebody else. So I'll show you pictures shortly, but the rash starts as a bump and then it becomes a little fluid-filled bump. And over time, that fluid-filled bump gets a little soft and has a little dimple in it. Then it starts to develop, where then it starts to open up and drain, and then a scab develops. This is all quite lovely. People are, you know, they really struggle with what's going on their skin. And then after those scabs sort of fall off, that's the point where the infectious period stops. So that's because the skin underneath the scab is healed over. It's actually turned into normal skin. And then the recovery period, the good news, if there's any good news with this, is that there doesn't seem to be any long-term effects of this. There's not a long COVID version of monkeypox. So when people recover, as far as we know, and again, this is kind of early, but there's no expectation that there's a long-term chronic condition of this. Next slide. So this is the beginning of the graphic image section. And some of these are going to be tissue and rashes on the body, on the genitals, on the buttocks. I chose these pictures because I wanted to make sure people could get an actual good view of what this is. Like, you don't want to be worried about mosquito bites this August because we have plenty of them. I'd like to show you how this differs from common things. And I'm also going to include some things that are sort of the worst case scenario, like a very bad presentation of it, not to scare you, but just to tell you, this is the extent of it, okay? So if you'd like to minimize your screen, this is the time to do that. And there's only this one period where we have the graphic images, so I'll let you know when we're done. Okay.
I'll just give people a couple of seconds here. And yeah, thank you so much, Janet. I think this is really important stuff to also convey out to the community. And although it can be a little intimidating and graphic, and we definitely don't do this to spark fear in anyone, but really to just make sure that there's really great, accurate information out there for folks. Okay, so that's everyone's last warning. So I'm going to click through to a couple of images now.
Okay, so this first set of images, you can see that it tells you what day. It's like when people started their first symptoms, that was day 1. So you can see the what we would call, we actually would call something like an eschar, which is just a big scab with a lot of inflammation around it. That's on day 9. And when you look at the close-up of day 19, the frame to the right, you can see that there's this rolled up border around the scab. And that seems to be pretty common in a lot of these monkeypox lesions. And over time, give it a few more days and this scab is, it's just very slowly healing. It's taken its time coming off. Over to the right, we have day 25. The scab has finally come off, and underneath that, you've got healthy skin coming through. And day 46, so we're almost 7 weeks out. You've got some healing going on, but it is going to take a while. This is not something that people go through, in a short period of time. Okay, next slide. Now this is a picture of an atypical version of the rash, what we call a maculopapular rash. That's just red bumps. And these have occurred on this patient's torso and on his buttocks, and they're kind of confluent, like they flow together in the buttock area. If you give this enough time, it will turn into the vesicles. So this is why we want to have, like if I see a rash in my office, I'm always thinking about monkeypox now, if it's a possibility. But that's something that could just as easily be caused by, a penicillin reaction. So it's not necessarily monkeypox when we see this. Next slide. Here's another case. I wanted to show this less about the unusual rash on the left and more about on the right. This is the throat, obviously, and you can see the uvula, the little hangy down thing in the middle of the throat. And on your screen, just to the left of the uvula, to the patient's right, you see that ulcer on the tonsil. So that is the monkeypox lesion. So you can definitely get these lesions in the mucous membranes. And that's where they cause the most pain. So the skin lesions, at least in my experience so far, the skin lesions have not been as painful. It's when they happen in the mouth and in the rectal area, that's when they cause the most pain. So this person probably had swollen lymph nodes on the side of the throat, probably had a lot of pain swallowing. I would probably want to give this person some good pain medicine, and I might want to admit them to the hospital to make sure that their pain was controlled. Next slide. So this is a penis, and I want to start out by saying that this belongs to a man who is on very significant medical immune suppression for, I believe he had Crohn's disease, but this is the kind of immune suppression that makes him very susceptible to almost any infection. And if I have to compare that kind of immune suppression to the immune suppression that many of my people with HIV have, it's much, much more, it's much worse immune suppression. He's far more susceptible to infection than my folks with HIV. So with that said, this starts out, and I show this at the beginning because the lesions on the penis on the left and in the second frame look pretty typical. They start as little bumps, and you can tell there's a little bit of fluid in there. And then as the inflammation worsened, you can see the massive amount of swelling of the soft tissue there, which, to me, I think that must be excruciating. And so this is how inflammation does show up in the penis if there's any kind of an infection there. So we generally put someone like this in the hospital to make sure that they're followed by a urologist and make sure that they get good pain medicine. But again, this is somebody who had no immune, basically he came in pretty much completely immune suppressed. Next slide, please. Now, over time, you can see the inflammation on days 7, 8, and 9 kind of progressed. And as that redness on day 9 gets darker, that's actually a sign that he's beginning to heal. The lesions themselves don't change that much. And then we go to the next slide. And to me, this looks like a tremendous relief by day 16. And you can see that there's now scabbing of the lesions. The inflammation has markedly reduced. And he's actually going to make a full recovery. Next slide, please. Now, these are pictures of the anus, and I think this is one of the hardest areas to figure this out, because what you can see in that the first slide, it's kind of hard to tell if that's just an irritated anus or, if there's something going on there. And if somebody came into me with that and pain, I would definitely be looking for monkeypox. In the second frame, you can see that there are little bumps there. Again, I'm looking for monkeypox there. Now in the third one, you can see these are more typical of the things that I've shown you already. And then that is much more characteristic, but it can be difficult to tell if a lesion in the anus is actually something worth swabbing. So that's why I'm much more attuned to pain in that area. Next slide, please. And I think that's the end of our pictures.
Yeah, thank you. So for folks who had minimized their screen during that part, you're definitely invited back to continue on with the video portion. There won't be any more images like that in the rest of the talk.
Yeah, definitely don't hit the backspace, Cameron.
I know, I'll do my best.
So I'm going to wrap up with a couple of other slides because I want to get to the questions. Can monkeypox be transmitted any other way besides sex? I think we talked about this. Intimate skin-to-skin contact is the most efficient way to transmit the virus. And viral transmission is actually a product of the dose of virus and the duration of exposure. And so when you think about somebody who has some of these really, a lot of inflamed lesions in one area, if you're close to that area, skin to skin for an hour, good long cuddling session, that's going to be more likely to give you monkeypox or to transmit monkeypox than if you just brush up against that area, as you're walking through a crowd. And so it's very important to think about viral transmission as a dose. So, and most of that dose component that we can control or be aware of is the duration of exposure. And so, again, monkeypox lesions are most infectious from the time that they appear until the time that the scab falls off. And as you've seen, that's a very, that can be a very long time. Next slide. I said I wasn't going to have any more pictures, but this is just of a hand. This is another presentation of how this, how the lesion evolves over time and how the scab falls off. I think that's all I wanted to say in that one. Next slide, please. So in our day-to-day activity in our day-to-day lives and our very eventful lives and special times and just regular old times, we have to think about now what is our risk for acquiring monkeypox. And Cameron actually shared this with me, thank you. And I'd like to go through it because it's just like safer sex. We have to sort of think about what is the safest and, the least safe, and engage in these activities if they're right for us. And so the most risky activity is going to be direct contact with the infectious rash, scabs or body fluids, sexual or intimate contact. And, condoms are only going to cover the penis. And so they do not protect against monkeypox transmission because the lesions are usually not just confined to that one area. Less risky than that, but still on the risky side, is fairly innocent things like kissing and cuddling and dancing at a crowded party inside with non-fully clothed people. These are lots of fun, and you don't like to think of them as being risky. They aren't risky for, the things that we're most used to thinking of, like HIV and hepatitis C. They are risky for monkeypox. So next is the possible thing, the possible risk, sharing a drink with somebody. That's not easy, because I think if I were going to get monkeypox from somebody by sharing a drink with them, I'd really expect them to have monkeypox lesions in their mouth. I wouldn't think that sharing a drink with somebody who didn't have a lesion in the oral cavity would actually give me monkeypox. Now, sharing a bed or towels or personal toiletry items, this is a little bit more. I'd actually put that much higher up than the sharing drinks part. There is only one case that I'm aware of. There may be a few, but there's certainly less than 5 cases of healthcare workers actually acquiring monkeypox. And this dates back to one of the Nigerian outbreak. And what it is thought to have happened is that a healthcare worker picked up the sheets of somebody who had had monkeypox lesions, and they just kind of shook them as they were trying to put them, into the hamper. And what happens when you do that, and I'm mentioning this because I think there are other things that we do that are like this, and I'd like you to be aware of it. That actually, in a sense, sprays, infectious material into the air. And when we think about, you sometimes see that masks are necessary and that you can breathe the particles in by respiratory droplets. This is probably the only way that that's going to happen, because it just, sort of with a lot of mechanical force puts these infectious particles up into the air. And if you're not wearing eye protection, if you're not wearing a mask over your nose and mouth, it is at least theoretically possible that you could acquire it that way. The other way that it could happen is if you're touching these sheets without gloves on, or if they contact your arms and you're not careful about trying to wash the area, and then you wipe your nose with your arm. So those are possible ways of doing it. Now, here's the thing. If those were likely, we would see a lot more healthcare workers, a lot more family members having this, and we're not seeing that. So I want to make sure that you're aware of that possibility, but also know that this is not how people are getting it in this outbreak. I won't say that nobody's getting it that way, but it doesn't seem to be an efficient way to transmit it. And then next item, dancing at a crowded party inside with fully clothed people, that's probably not going to do it. It's hard to get monkeypox if you're dancing outside, and the outside thing has to do with just more air movement with clothed people. Coworker to coworker transmission, trying on clothing at a store, touching a doorknob, traveling in an airport, on a plane, in a swimming pool, hot tub, or a body of water, public restrooms, public transit, grocery store, coffee shop, gym. These are all, if these were efficient ways of transmission, we would be seeing people who were not, we would be seeing sort of a wider distribution of who is getting the virus. And I think, let's go to the next slide. I'm going to go through this kind of quick. Have I been exposed to monkeypox? So this comes up when we think about availability of the vaccine. The CDC classifies exposures into high risk, intermediate risk, and low risk, and this is available on their website. It's mostly geared towards helping healthcare workers figure out if they've been exposed. But I'll just at least make reference to this because I think this is a little bit artificial outside of a healthcare setting. I like what I just showed you, so I just want you to know that this exists. And next slide. And then this is actually, I think from our website about monkeypox vaccine eligibility. And you probably have seen this or have been aware of it. Vaccines are out there, but are, I think we've gone through our supply. The Philadelphia Department of Health determines who gets the vaccine in our city, and we're following that. So you must be, to get the vaccine at this time, a gay or bisexual man or a transgender non-binary person who has sex with cisgender men or transgender non-binary persons, also be 18 years old or older. And you must meet at least one of the following criteria. You've had multiple known or any anonymous sex partners in the last 14 days. You believe you've been exposed to a sexually transmitted infection or monkeypox in the last 14 days. You've been newly diagnosed with a sexually transmitted infection in the last 3 months. In other words, gonorrhea, chlamydia, and early syphilis. And so this just tells you the number, and I should say anyone regardless of gender identity, sexual orientation, who's exposed to monkeypox should be eligible for a vaccine. So it's not, that's sort of a qualifier to all of this. And so I think that's my last slide, Cameron.
Great. Let me stop sharing this. Well, I just want to say before I pass it back to Jason and the question part of the conversation, thank you so much, Janet. I learned an incredible amount in the last 30 minutes, and I've been following this for a long time. So thank you so much. I think that foundational knowledge and the narrative from 50 years ago is really sort of important to kind of put us into context today. So thank you.
Thanks, Cameron.
1000%. Thank you both. Janet, that was a great presentation, extremely informative. While you were giving the presentation, I received a lot of texts and emails already. One, cute cat. I've gotten that a few times. And also, just a lot of thank yous for, providing all of this helpful information so far. Thank you again. So for those who have just logged on or have joined in the past, 20 minutes or so, thank you for joining the Philadelphia Fight Community Conversation on Monkeypox. We have just heard a talk from Dr. Janet Hines, and we call it Monkeypox 101. For anyone who had missed it or missed the beginning part, the full recording will be available on the Facebook, on the Philadelphia Fight Monkeypox information page at www.fight.org. I'll drop that in the chat. Additionally, it will be on the Facebook page of JD Evans Solutions, which is where you're watching this live stream, as well as other social media pages throughout the community from our partners. And with that, now we're going to pivot into the questions that we received from the community. As part of the RSVP, we had options for people to ask questions about monkeypox and get the, what we're going to try and do is answer some of those questions directly from the community, whether it was sent via RSVP, whether it was sent by email or text, or people that grabbed us on the street, because that did happen. People were just, have lots of questions. We wrote them down and we want to get those out to you. So with that, let's dive into the conversation. A lot of people in the community are service industry people, whether you work in bars or restaurants or what have you, hotels, it runs the gamut. So we had a lot of questions that revolved around that. We tried to consolidate some of them and answer some of those questions right off the top. So with that, there are people in the hospitality and service industry who have concerns about physical contact with their clientele and are curious what the risks are and if they should be doing more to protect themselves. And to give you an example, we'll use a bartender. Bartenders are, sometimes in contact with people, there's money being exchanged, tips being exchanged, so what advice do you have for those people? working in those areas.
Yeah, thank you. First, I'm just grateful to the profession because, you know, one of my favorite things is just being out and being taken care of by people who are in the field. So with gratitude, but what I would first say is that handling money and handling credit cards is a controllable risk. It's, as I mentioned before, the likelihood of transmission has a lot to do with the dose of virus and how long you're in contact with the virus. So if you take someone's credit card, that little catastrophe going on here, I apologize. If you handle someone's credit card and they have had their credit card stored in, you know, some nether region that is right there with monkeypox, it is I'm not going to tell you that anything is going to be a safe thing. Okay, just along with like safer sex ideas, you know, there is no safe activity other than just never leaving your house. So but this is a pretty safe thing to do if you're mindful of the fact that hand washing with Purell, you know, with alcohol-based sanitizer, is a very effective way of eliminating that virus. And so what that means is that if you've made that transaction with the credit card, you've held the credit card for maybe 20 seconds, whatever, 20 minutes, wash those hands, you know, afterwards. I am not a fan of gloves in this kind of a setting. I think everyone has to make their own decision, but while it might make sense that gloves would be a great way to protect the hands, gloves stay on when you have, you know, an itch on your face or, you know, your nose itches. And so it's very, it's not always, we're not always successful at avoiding putting the gloved hands on our face. So I'm a much bigger fan of frequent hand washing. Now, when it comes to closer contact, so the type of setting where more than just a credit card is exchanged, you know, hugs and things like that, those are going to be less safe. And I think if the transaction would allow you to control your ability to contact somebody, then it's, you know, it's ideal to try to have less skin to skin exposure. And I'd like to, you know, optimistically say that at some point, you know, maybe all the people who are hearing this will already be vaccinated. And I'd like to think that that point is going to happen when we're just going to say, you've been vaccinated, you're okay. I think that point is actually going to happen. So this is a short-term period. My hope is that we can do this now. But if you have to have closer contact with people and you can't avoid it, make the contact of shorter duration. You know, if it's possible in your profession to wear longer sleeves, I think that's almost impossible in this weather. That would be something. I think the idea of soap and water or, you know, alcohol, hand sanitizer, body sanitizer is probably something that could be useful. But casual contact, you know, if this is a setting where, you know, you're putting plates down, picking plates up, that should not be something that you should think about monkeypox.
Great, great. No, thank you. And you kind of touched on the next question I had that had come in. There are people that work as entertainers, also in this industry. You know, we have dancers, drag queens, you know, all kinds of performances going on around the city. There's a lot of casual contact, you know, like especially if one of your performers is in a pretty, you know, Little Mermaid outfit or whatever, or Cinderella, it's beautiful, you want to see it. And, you know, there's, you know, handshaking and, you know, when they're exchanging tips, you know, it's very common practice to put the tip in the performer's hand and then they drop it or stuff it in their wig. You know, so, you know, how about that? There's a lot of frequent touching in a crowd. What are your thoughts on that?
Yeah, I think when you multiply the number of people that interaction, involves, like the number of people between hand washings, so to speak, that makes the risk a little bit higher. Um, I, I can't get to the point where I can tell you this is how you can prevent that. I think I, I can only tell you that these are brief interactions. They're not sexual interactions. They're not, and what I mean by that is that, we're not talking about something that lasts, 20, 30 minutes, 2, 3 hours overnight. We're talking about brief interactions. And it's hard to get infected that way. I don't know, like, if I were in that position of trying to decide how do I go about my job, with somebody telling me, yeah, it's hard to get it, but you're still touching a lot of people's skin in the course of your job. You may touch, 30 people over the course of your evening. I can't tell you that you're not going to get it. But I can tell you that we're not seeing entertainers get it. We're not seeing people getting it predominantly on the hands. So it's unlikely, but that may not be enough to help you sleep at night, unfortunately.
Okay. Okay. Thank you. And while we're in this area, what about people who engage in sex work? What can they do? Because, this is their livelihood in a lot of cases. What can they do, those working in sex work, do to protect themselves and or reduce risk for themselves and others?
Yeah, so I think it may or may not be, there may or may not be the opportunity to make the discussion, bring a discussion of monkeypox to that setting. As a business transaction, if we're going to do something together, I may have monkeypox, you may have monkeypox. Let's talk about this. What does this mean for me, and what does it mean for you? And and I realize this is not realistic in all sex work, but if it is something that someone feels like they can engage in, an actual conversation, then the idea of where, do you have lesions? Is it okay if I say something, if I see something, that kind of thing? That's certainly not going to be realistic for most cases. And if there is a way to be more protected, like to keep more clothing on, to keep less of the body exposed, that would probably be one approach. But it's funny and ironic that I'm the one being asked this, so I can tell you the information about how it's transmitted, and it all gets down to that duration of exposure. I think I would probably learn a lot from talking to the folks that I take care of about what their thoughts would be. So I feel like I may be an expert in some things, but I'd love to brainstorm and hear about what other people think in that area.
Oh, that sounds like an opportunity for another one of these Zoom sessions down the road. So maybe we could talk about that after this one. Thank you very much. Now we're going to move into a little bit more of the risk of exposure. How do you get different modes of transmission, which you touched upon in the 101 section at the beginning. But we did get a lot of questions on how you can get it. Some of these we've seen come up before, and with COVID and HIV and AIDS. So there are a lot of the same questions that people are curious about transmission. So let's start with: is it possible to catch monkeypox from a toilet seat?
Yeah. So that's one of those things where, like, the theory and knowing about the biology of the virus, it might lead you to conclude that you could catch it, because unlike the traditional sexually transmitted infections of gonorrhea and chlamydia, they don't last long in outside of moisture, but monkeypox is said to be able to stay on a surface and be viable, be be live when it's on the surface. However, again, we're not seeing cases in people who just are using the bathroom. So my conclusion based on what we know about all of this is that I would say, no, you're not going to get it from a toilet seat. If you, probably the only time that I would say, I like to think of it this way, like if I wanted to catch it from a toilet seat, what would I have to do to get it from a toilet seat? I'd probably want to be in a household with somebody who has monkeypox and has a lot of lesions on them, on their backside, have them sit on the toilet for a long time, and then go in right after them without cleaning the surface at all. So, and I still am not sure that I would get it that way, because again, it's the epidemic is not being seen in people who are not reporting sexual partners. It's very, very few people are saying they don't have sexual partners. So I would say the answer is no.
Okay, all right. Some of these we answered earlier. I'm going to skip through, like, is kissing considered risky behavior? You covered that in the chart, so thank you for that. Also, what do you think, this has been a very popular question, and it goes back to that chart of how casually can monkeypox be contracted? And we touched on it, but, is there any way you could elaborate a little bit on that briefly?
Yeah, I would say that when I think of casual, I think of just, like you brush up against somebody, for probably a second or two. That's not enough time. That's not enough time. So I think if you're, in the crowded subway, crowded bus, crowded shopping center, that's not how you're going to catch monkeypox. I was going to say COVID. It's not how you're going to catch monkeypox.
Okay. All right. And speaking of, can you, grocery stores and thing of public spaces, can you talk a little bit more about the risk of exposure via air droplets? There's been a little bit of conversation going on in different spaces talking about air droplets, the aerosolization, and is masking important?
Yeah, this I'm going to be a little triggered here because I feel like I'm probably not supposed to speak against, as a professional infectious disease person, probably not supposed to speak so much against the CDC, but I am absolutely enraged that they are giving support to the idea that this can be transmitted through aerosols and through droplets. It is simply, the epidemic simply is not behaving that way. And what the effect is that, people have been through COVID, and where you can be around somebody who you have no idea if they have, infection, and you're just innocently hanging out with them. And the next thing you know, you have this potentially life-threatening infection. So I think just the experience of living through the COVID pandemic has really made all of us feel really distressed about our vulnerability of being around other people. Mm-hmm. And when the CDC and other public health authorities have implied that you have to wear an N95, which is the highest protection in order to protect yourself, it just displays it's a betrayal to me. And I don't think, like, I would feel perfectly comfortable walking into a room with a patient with monkeypox with just a regular mask on, like a surgical mask. And even then, like if I went in and, sorry, more catastrophe. If I went in with no mask, like if I was around somebody, a friend who had monkeypox, and I wasn't wearing a mask, it is said to be a little bit more of an exposure than just not being around them at all. But I truly believe that is not how I'm going to get it. It's not going to be that way. Now, the exception to that, is when there's a lesion in the mouth. And, like I showed a picture of that, and, we certainly have seen folks in our office who come in with a lesion or two in the mouth. And this is where, they could potentially get the virus into the air. But now these are in droplets, and those fall to the earth very quickly. And so if you're going to catch monkeypox that way, you have to be probably in close contact for several hours with somebody, meaning, like a face-to-face conversation for 3 hours. And that happens, but again, that's not where this epidemic, that's not, the people who report the risks are not people who are just having a conversation. So the other thing that I mentioned is the idea of like flinging up the bed sheets. If somebody has monkeypox and they have, draining areas, or, like their scabs are coming off, and you come in and you're dealing with the laundry, and you just pick up the sheet so you can take it off the bed, that's a potential for getting some infectious material in the air. Again, I think it's very, very unlikely, but I don't want to say that there's no risk to those two things. But I feel like when the CDC started saying that we need to wear N95 masks around somebody with COVID, I just get angry. I just, it's bad enough for me to have to walk in with, the gown and the gloves and everything, and to have like a big mask plastered to my face it feels wrong. So sorry, I'll get off my horse.
No, I appreciate it.
And I just want to clarify, you said COVID right there, but I know you meant monkeypox.
Yeah, but I can't get away from it. Thank you.
I just want to make sure we're putting the right information out there. So yes, monkeypox.
Yeah, great, thank you.
Thank you. Okay, and as we're talking about bed sheets and flipping things around, like, so what are your thoughts on, is it safe to be in a household with someone if they have been exposed to monkeypox or they currently have monkeypox? Can you talk about isolation and what, this isn't easy for some people. Some people may not have the ability to isolate or quarantine themselves from the rest of the household. So what can you talk about that a little bit?
Yeah, I think this is a really tough one, because I think when I first saw my first cases, I was like, who's at home with you? And when they were like, nobody, it's just me, I'm like, thank goodness, because I don't know how we're going to manage this. Now more time has passed since then, and the idea of isolating yourself in your home, whether it's COVID or monkeypox, is super hard. Now, drawing on what we know about how it's transmitted, well, let me back up a minute. What you see out there from public health authorities, whether it's CDC or city, whatever, they put recommendations for how to prevent acquisition of monkeypox in a way that they want to give you the most protection possible. And so the guidelines that they give you sound extraordinarily difficult to follow through on. And I sort of think of it as a harm reduction approach. I mean, if you have a mansion and you can live at opposite ends of the mansion for a while until things get better, great. But aside from that, you have to kind of decide what are the things that you do and that you don't do. Number one, probably not a good time to have sex. Probably not a good time to cuddle. Probably not a good time to, have naked hugs. This is stuff that if you can manage to do that, great. Now, back in the other end of this, sometimes you can't manage to do that because you don't have control over your situation. And if you are in a situation where you're having to have close contact with someone with monkeypox, covering the lesions is going to be the best thing to do, if that's possible. So, aside from that, with the with taking care of somebody, do you want to put gloves on to be around them? maybe, this might be a time to invest in some gloves to take care of their laundry and things like that. Do you want to put on gloves to serve them their meal? Probably not. That's not going to be a high risk thing. But contacting their skin is something that, this might not be the right time to do it.
Bathing, adjusting them in the bed and changing dressings and things of that nature, gloves would be definitely recommended.
Yeah, for sure, gloves. And if you have the ability, like we have gowns in the healthcare world, something that you can put on that is, goes down to your wrists and covers your whole front, because the clothes, if your sleeve is in contact with a lesion and you don't know it, that could then be what gets it on you.
A means of transmission, right?
Yeah, so being able to kind of cover up the your own clothes as you're taking care of somebody
Right.
would be the thing. Yeah.
Totally makes sense. Going back to an earlier, when you were going through the one-on-one and there were some pictures in there, some of the pictures that you shown were a lot more intense than what we've seen on the news and online. So one of the questions is, that I was sent was, does your skin go back to normal? Like once you've healed, treatment or whatever, after, a certain amount of days, once you are no longer infected with this virus, do things go back to normal? Does your skin go back to normal? Does it leave marks behind like monkeypox can and other different?
Yeah, so I think when you think about the fact that this is this epidemic is what, 2.5 months old, and some of the lesions I showed you were like 40 days out. So we're still kind of ascertaining what's going to happen with these skin lesions. I can sort of go back from, like I don't think much is reported from the endemic areas. The Nigerian outbreak, I don't think much is reported about scarring from that situation. But what I would say now is that you can have the expectation that these lesions will heal completely. I think one of the best ways to do that is to allow the scab to form and come off on its own, not to pull the scab off, which I think is hard for some people to do. But letting the scab just come off naturally is probably the best way to prevent a scar. But it doesn't have to scar. It's not as if everyone who gets monkeypox is going to be scarred in those areas. I think we just kind of have to see how this is going to heal.
All right. Thank you. And for this next section, we're going to pivot to Cameron for a little bit. Cameron's going to take it over from here for a brief second. So Cameron, take it away.
Yeah, thank you. And hopefully some relief for Janet too. I know all of those risk questions and exposure questions are really tricky to answer because it kind of falls on the spectrum and there's a whole lot to consider. So hopefully bringing in some quick kind of yes or no sort of kind of instant back questions for you so we can all sort of like take a little breath. So we talked a lot about risk of exposure. We talked about mitigating risk. Now, we'll kind of move into a scenario where you think you've been exposed. What can you do? Lots of folks have had questions about where they could go to get tested and how available that is right now. That always comes with a secondary question of, is there a cost and do I need to be insured to access a test? Could you say a couple of comments about that?
Yeah, so I think for our folks who are get their care at our health centers, we want to see you if you have been exposed, because ideally, if you've been exposed, we would give you monkeypox vaccine. If you're not a patient of one of our health centers, I think the health department, Mazzoni, wherever your provider is, you want to be in contact with them as soon as possible. The idea of I think it's a hard thing to answer about the vaccine and availability, but if we were to assume that, let's just say we get to a point where we have a good supply of vaccine, yeah, we would give you the vaccine as soon as we heard from you. And the idea is that if you can get it within 4 days of your exposure, it's going to do a really good job of preventing disease. it's after 4 days up to 14 days, we think that you might still get monkeypox, but it'll make it less severe. And then regarding cost, I have to apologize. I was out of town as the vaccines came in. So I'm pretty sure there's not a cost to these, and maybe you can confirm that for me, but I'd be surprised if, I don't know. I mean, we exist to make a small number of people really wealthy on healthcare, but sorry, I'll keep my, not at Fight, but certainly everywhere else. Yeah, I don't think there's a cost. Am I right about that?
Yeah, I don't believe so. And I mean, it's much easier for me to speak from the perspective of Fight and from federally qualified health centers that cost would never be an issue to prohibit someone from getting a test or from getting care. So I appreciate that. I think we covered kind of what some first steps would be for someone who thinks that they've been exposed. Definitely contact your health provider or the health department. Ask about getting a test, potentially accessing a vaccine quickly after exposure. And I think we covered a lot about what someone might be expected to do when it comes to isolation and quarantining if they do come back positive for monkeypox or start exhibiting some of the symptoms that we talked about. This is a conversation that's been kind of growing in my network, which is the considerations for folks who do find themselves needing to isolate or quarantine. A lot of folks, even some of the staff at our own health center, have expressed concern around what does that mean? How does that impact my work, my income? What sort of mutual aid or resources are out there for folks who find themselves needing to isolate or quarantine away from a job? This is something we obviously experienced a lot of over the last 3 years with COVID, but I just really I've heard a lot of that in the last even just 72 hours and really want to elevate that, not as a question necessarily for you, Janet, but just as a consideration that, as you showed in that diagram up front, this isn't a 5-day disease. This is a pretty significant amount of time, and that can really have a lot of impact on people's ability to live. And I just want to kind of honor that and uplift this conversation about finding more ways to provide mutual support and care for folks who do have to isolate or quarantine. If you wanted to comment at all.
I agree completely, because that's one of those things where, when the question comes to me, I come up empty. It's so necessary to support somebody who needs to not, go into work. I again kind of think of a harm reduction standpoint where, if lesions are covered, it's hard for them to transmit. And I think that some people just have to do what they have to do. And I wish that we would get to the point where we would be a little bit more accurate in our assessment of risk so that we could give guidance to people who need to work, and if they can cover their lesions where they are, let them work. We're not yet at that point, but I can imagine that would be quite possible to if people felt up to it.
Great. And before we jump into sort of the last section on vaccine, can you also, I realize that we're in a unique period of time where cases are on the rise and vaccine accessibility is incredibly limited. You alluded to it earlier that we hope to enter a new chapter as soon as possible where vaccine access is much more available to folks. But in this sort of unique chapter that we're in, can you talk about treatment? I've been exposed and tested positive for monkeypox. I don't have access to a vaccine. Are there treatments that are available for folks, or is it more just managing symptoms?
Yeah, so I think before I was away, the treatment was almost not available. And since that time, it's become, the CDC has changed the process so that it's much more easy to get. There are guidelines about who should get treatment, and it has a lot to do with the severity of illness. So people who have mucous membrane involvement, which you'd expect to have more pain, or people who are immune compromised. Now, when the CDC puts out their guidelines about about treatment, and they mentioned immunocompromised. They're not very precise about what that means, other than they, for people with HIV, they say a CD4 count less than 200. And then they have a long list of, people who are immunosuppressed because of medications or cancer. But I'll comment that it seems like, from the standpoint of my folks with HIV, a lot of times your immune system does pretty good in a situation like this. So I would not say that if somebody has HIV, period, that they automatically must get treated. Now, I'd like to think we live in a world where, if mutual decision-making happens and they want to get treatment, treatment can happen. What I understand of treatment, the primary one is TPOXX or tecovirimat, and it's pretty well tolerated. I have not had anyone go through this course so far, but I've heard about people who've gotten it, and it seems like it makes them feel better quicker. And again, this is available from the health department. I believe that there is no cost associated with it. And so, certainly we would do everything we could to make sure that somebody got that treatment if needed. The other aspect of treatment is important to mention is that pain control is important. It's, a lot of people have lesions that I think, wow, that should be really painful. And they're like, no, I'm good. I don't, I'll take some Motrin. But, some people have some pretty significant pain and they need to be hospitalized for it. So I think we need to prioritize the importance of treating their pain and make sure that they get what they need. This is a very important part, not just the antiviral, but the pain component.
Awesome, thank you so much. So I think we're gonna take one more pivot before we close out the evening to vaccines. And before I give it back to Jason for some questions, just wanted to reiterate some of what was covered quite a while ago at this point. So for folks who maybe jumped on a little bit later, we're going to talk about monkeypox vaccine. We do keep information about availability pretty up to date on our website at fight.org. Has all the information. You can also find all of this information on the health department's web pages about who is currently eligible. They have a new web page that really does a great job of sharing how many vaccines are available and on their way to Philadelphia. It is free. You do not need to have insurance if you're accessing it through Philadelphia Fight. When we did have it available, we don't currently at this moment. That would not be a cost to you. But we have some questions that have come in from the community about the vaccine itself that I'd love for Jason to be able to kind of walk us through.
All right, thank you, Cameron. Thank you, Dr. Hines. Again, just a quick reminder for everyone, for those who have just logged on or logged off in the past 20, 30 minutes or so, thank you for joining the Philadelphia Fight Community Conversation on monkeypox. Cameron and Dr. Hines have been talking about some of the risk of exposure and hospitality, service industry, and covering a lot of areas. For those who have missed the earlier parts of this event, this full recording will be available on the Philadelphia Fight monkeypox information page. That's at www.fight.org. It's also, I dropped it into the Facebook Live, so the link is there. Also will be available on the JD Evans Solutions page, as well as other social media pages throughout the community from our partners. And we are going to roll into our last segment. I know we're going a little bit longer than we had planned, but this is information we need to get out there. So we want to make sure we cover it all. Dr. Hines, there's a lot of information, a lot of questions about people who have the smallpox vaccine, especially those who received it prior to the 70s. Some of the people have the little, the bumps over here. Like my sister and brother were like, oh, we got this, we got that. You don't have it. I was born later, as you can tell from my skin. Do you think, do you have any guidance for those who were vaccinated with the smallpox vaccine, prior to 1972? And do you have any guidance for those people? Do you think the monkeypox vaccine is necessary, or are those people protected already?
Yeah, I think I love this. It's based on the outbreaks that have happened prior to this 2022 outbreak, it seems that it, I never know.
Waiting to pounce.
Exactly, yeah. So it seems that the smallpox vaccine has a vaccine efficacy of about 85%. Now, it's a little, I think the reason that people haven't just said, okay, you've had smallpox vaccine, so we're not going to give you monkeypox vaccine. So nobody has said that, and I'm glad, is because I think there's probably quite a bit of variability there. I do think that this was a tremendously successful vaccine, and the current vaccine is not the same as what was given back then, but certainly modeled on the same idea. So, I mean, if I had to guess, I expect that there's probably quite good protection if somebody who's been immunized against smallpox actually does get infected with monkeypox. They're probably going to get a mild case. And so, yeah, I think it probably is quite good for people who've gotten smallpox vaccine. And whether or not they get a monkeypox vaccine probably has everything to do with supply. Like if you've had your monkeypox vaccine, but or smallpox vaccine, and you're, over 50, but you're at super high risk because you're a sex worker, get that monkeypox vaccine. I think if you're, if your risk is high, you should probably get an additional dose.
Okay, thank you.
Alongside the question about the smallpox vaccine, kind of related to folks having individual concerns around vaccination, and I know, Janet, you're well primed for this question, is really what we're thinking about, and we touched on this already, folks who are immunocompromised, some folks who do have conditions that leave them immunocompromised. I've asked questions about whether the vaccine is safe, are there additional risk factors, and then I think likely because this is an infection that predominantly is infecting and impacting people's skin, there have been a number of folks with psoriasis, eczema, atopic dermatitis, who are also kind of thinking about this a little bit more deeply. So love to open it up about sort of vaccine safety and considerations for folks who are immunocompromised or living with autoimmune disorders.
Yeah, thank you for that. So there are two different smallpox vaccines available. One of those, which is the Jynneos, is the newer one, and that's been approved for monkeypox. The older one is called ACAM 2000. And the reason that we try not to use that one is that it's a weakened virus or an attenuated virus, but it's still replication competent, meaning that it is able to reproduce in your body. Now, if I have eczema or psoriasis or another, atopic dermatitis, and I get the old ACAM 2000 smallpox vaccine, I can have a severe total body reaction called eczema vaccinatum, where it's just like I get a super bad case of eczema as a result of getting that vaccine. So we should never give that vaccine to people with those skin conditions. The newer vaccine called Jynneos is it's also attenuated or weakened, but it's replication incompetent, meaning that it cannot make more copies of itself in your body. So you inject the virus, the body makes a reaction to it, it kills the virus, that's gone. Because it can't reproduce in your body, it doesn't give the people who have atopic dermatitis and the other conditions a skin reaction. So it is felt to be safe in people who have those skin conditions and in people who are immunocompromised.
Great, thank you. And just to sort of clarify, I think most people kind of know the answers who have been following this, but the newer vaccine that you mentioned, the safer one, the Jynneos vaccine, is what people are getting through the health department and through these outreach efforts right now.
Are you asking or telling?
Asking, but I know the answer. I just wanted to make it clear for the folks on the call that if they're trying to access a vaccine through the health department or anything, that they're not going to run up against that older vaccine and have to have that concern.
Okay, yeah, because my brother actually texted me earlier this afternoon. He's in Florida and he's like, I'm sitting here waiting to get the monkeypox vaccine. And I said, is it Jynneos or ACAM 2000? I was like, it's Florida. So I needed to make sure. So he got Jynneos. But yeah, I think that's an important thing to say. So thank you for that.
All right, so I think just a few more questions that we have related to some of this. I guess I missed a couple here on my bucket list here. So what for folks who are vaccinated, is there a possibility, or what is the possibility of catching monkeypox anyways? And should we as a community expect to see other vaccines like we sort of did with COVID as the months went by, more vaccines were available, or is the approach really to just ramp up the availability of the vaccine that we have right now?
Yeah, so let me answer that one first. So I think I know the company that makes the Jynneos is claiming that they can increase their capacity and that they're going to make a lot more doses available, but certainly not as quickly as we want them. I know that Moderna is trying to get into the act and make a monkeypox vaccine. Certainly that's going to be a ways down the road. So I would be surprised if we saw something this year. But I think that this probably is going to be a vaccine that everyone should get. It down the road, there's no reason that everyone should not be able to get this, but certainly high risk people first. So any biotech company would probably make a ton of money off of it. So great. The question about can you get monkeypox anyway if you've been immunized? I think we don't know the answer to that yet because it just hasn't been enough time. Vaccines are just now rolling out, and there is. I wasn't able to kind of put this into the presentation, but I know that at the AIDS 2022 conference, there's a presentation about the immunization efforts in Montreal, and you can't necessarily tell in a given person, at least in that population that they were giving the vaccine to, how effective it was at preventing monkeypox, because you don't know if you've given it to somebody who just got exposed, within the last week or so. So somebody could still get monkeypox after the vaccine if they were already infected with it. However, when you look at, you talk about flattening the curve when COVID first came out, they have been able in their vaccine efforts in Montreal to flatten the curve so that the number of new cases, instead of just continuing to rise, is actually dropping over time. So I do believe that this is going to be, and that's the Jynneos vaccine, I do believe it's going to prove to be an effective vaccine. And I want to insert one question because I think it probably is going to be on the minds of anyone who has plans this summer. If I do get the vaccine, at what point am I protected? When can I go on that trip that I want to go on or do what I want to do? There is the sort of standard answer that we got with the COVID vaccines of, well, you have to wait until 2 weeks after your second dose. So the Jynneos vaccine is a set of 2 doses 4 weeks apart. And the standard reply is you have to wait until 2 weeks after the second dose. However, just recall that if you give this vaccine to somebody who just got infected, they're already infected, and you give it to somebody 3 days after they got infected, and it can prevent infection, I think it's actually probably pretty good. So I wouldn't tell you to make your decisions based on what I just said, because there's no data in that. I think you have to make your decisions based on all the uncertainty of the fact that this is a very new vaccine. We haven't seen its performance yet. But I would be, I guess, optimistically hopeful that a year from now, we'll find out that this is the kind of vaccine that really starts to protect people pretty early. So, please don't make decisions based on that.
Yeah.
I'd be very cautious.
Before I kick it back to Jason for our last couple of questions, just to sort of throw out there too, that right now, at least with the very limited supply of vaccine that we have access to in Philadelphia, it's unlikely, if not really unheard of, that folks aren't getting a double dose right now, that the idea is really to get one shot into as many people's arms as possible. But in time, Janet, I think we would presume that we would like to come back and give boosters to people when supply goes up.
Absolutely. Yeah.
All right, Jason. Couple more, and I think we've almost wrapped this up. So thank you, everyone, for hanging in with us.
Okay. There, as we're talking about shots and people getting the vaccine, excuse me, there's a lot of questions about, how long will the vaccine last? What is the efficacy rate, or how frequently do I need to be vaccinated? There's a lot of guidance that says, 2 shots, 28 days apart. As Cameron just mentioned, right now, we're trying to get as many shots into as many people as possible. So we're doing 1 shot. The CDC is recommending 1 shot instead of the recommended 2. So what are your thoughts and guidance on, what are the next steps? What does this look like? How protected are we? Will we be okay with 1 shot?
Yeah.
Do you see this as a ongoing booster shot type situation like with both?
Yeah, I mean, that's a great question. I think if you asked me or anyone that about the COVID vaccines when they first came out, everyone thought that, oh, this is going to be it. We don't ever have to get another shot. And, it turns out you just keep having to get more and more and more. I suspect that's not going to be the case with monkeypox, only because smallpox is not that way. The guidance that says that you should get a second shot at least 4 weeks after the first shot is, I think, based on the studies that they did, probably with smallpox exposure. Well, I don't know if I can say that for sure, actually, but I think that my guess is probably worth nothing right now, to be honest. I just think that based on the smallpox experience that we probably will just get a single shot. This is actually probably pretty good at protecting, get a second shot just to kind of seal the deal, at least 4 weeks later, and then probably we're done. But, I would not be surprised at all if a year from now I'm completely wrong.
Okay. All right. Well, thank you. Thank you, Dr. Hines. Again, thank you so very much. Cameron, thank you. Before I close this out, I want to turn it over to you guys for any final thoughts.
Thank you. But it's been really a privilege to be a part of this, and I appreciate all the wonderful questions and the really hard questions. I can't say I appreciated all the hard ones, but it certainly made me think a lot, and I think we have a lot to we still have a lot of work to do before we can get our minds wrapped around this. I think I'm not sure if I can come up with anything perfectly wise to say, but other than keep supporting each other, and hopefully we'll get through this.
Thank you.
Yeah. Thank you so much, Janet, for everything. I just had a chance to check out some of the comments on the Facebook page, and people are really, really appreciative of the information and the depth of information. And like I said earlier, I've even learned some things over the course of this call, so I'm very grateful. The only other thing I want to say is, and I said this to you, Jason, probably the first time that we started talking about this event, was that my ability to bring accurate and non-stigmatizing information to the community is limited by my own networks and resources. And one of the things that makes me most excited is to arm people with accurate information. And so for the folks who are listening in and who have taken the time to kind of hear us out and to find sources of information that are trusted, you will have a great impact in educating the community. I think the ripple effects from events like this and just being able to share this kind of information is really profound. So I'm really, really grateful to you both, but also to everyone who took the time to listen in and to share, what they might have learned from this conversation with friends and families and coworkers, because I think that's one of our strongest tools against misinformation. And I'm just really happy that we were able to get this out there. So thank you, Jason.
Again, thank you for this incredible session. Thank you for taking the time. Cameron, you and I have been working on this for over a month. Janet, I know you've been working on, you've been in so many meetings, getting up to speed. While a lot more than all of us going on, this information has been constantly changing. So your dedication to obtaining all that information and being able to relay it. I mean, and your time and everything has just been so essential to helping our community get informed, stay informed, and share with others. So I want to thank you both so much for taking your time. Really quick, in closing, this recording will be available again on the Philadelphia Fight Monkeypox information page. It'll be on their Facebook page. It'll be on JD Evans Solutions and searchable on Monkeypox under YouTube. I'd like to briefly thank the great team at Philadelphia Fight, including Mike Marsico and God, her name is slipping my head. Sandy, right?
Dr. Stacy Truskin.
Dr. Stacy Truskin, thank you so very much, and the entire staff and leadership at Philadelphia Fight for being a great partner and getting this information out. I'd also like to thank our community partners who step up to support, not just for this community conversation, but for so many of the causes we need amplified. So thank you to the Tavern Group, Knock, the Bike Stop, Charlie Salon, Salon for Men, Independence Business Alliance, William Way Community Center, Media Copy, Chatterblast, Philadelphia, Philly AIDS Thrift, Giovanni's Room, the Philadelphia Inquirer, and last but not least, everyone in Councilperson Dom's office. They are an incredible asset resource to the city, and thank you for your continued support. We can't do this work without you all. So thank you, thank you, thank you again. And keep an eye out. Hopefully we can do another one of these and keep people informed until this is over. So thank you all, and have a good night.
Bye, everyone. Thank you.
Bye. Thank you.